Hello, everyone, and thank you so much for joining us. This is Bethany O'Connor from Palladium, and I am absolutely delighted to welcome you to today's webinar titled COVID-19 and Beyond, Is the Private Sector Part of the Solution? We have a great broadcast for you today, and we'll begin with just a few announcements. First, this session is being recorded, and we will post the recording to the HP Plus webinars page, and the Palladium webinars page, rather. And we would love to hear from you, and we welcome your questions at any time. Please submit your questions via the chat box on the right-hand side of your screen, and they will be read aloud when we pause for questions. Also, these web conferencing platforms are getting a high volume of traffic these days, so we ask that you bear with us in case there are any glitches with the technology. We'll get it back working. Finally, we ask that if you are not speaking, please mute yourself to keep the line nice and quiet while others are talking. And that concludes the little announcements portion. And now it's my great pleasure to hand it over to Lily Koch, Team Lead for Newborn Health at USAID. Lily?
Hi, good morning, everyone. Really wonderful to have you here. Thanks for joining us. So I'm going to be one of the moderators this morning, and I'd like to start right now. Ensuring continuity of care for women, newborns, and children during the coronavirus pandemic requires a whole market approach that brings together the public, private, and civil society sectors. If you're anything like me, I think you've attended a lot of webinars lately, and through these webinars, we're learning a lot about the disruption of essential MNCH services and how the public sector is responding to the pandemic. But the private sector has been largely invisible in our global discourse. Understanding and engaging the private sector is important because it is the preferred source of healthcare for many people in many countries. And it is important to understand how it has been affected by the pandemic and how it has responded to it. USAID has had a long history of supporting the private sector as part of a whole market approach. In this webinar, we will hear a brief overview of USAID's private sector engagement strategy, followed by Palladium's support to the private sector in 3 countries, and how in each country the private sector has adapted to the new context of the pandemic while providing high quality MNCH services. Next, please. Next slide. And it is my great pleasure to introduce the speakers this morning. We have 6 speakers. We start with Susan Ray Ross, who's the Senior Private Sector Engagement Advisor at USAID. And then we have 2 people from Nigeria, Dr. Halima Mukaddas, Senior Policy and Advocacy Advisor from the USAID Integrated Health Program, Nigeria. And then we have Dr. Olufunke Folade, Senior Health Financing Advisor, USAID Integrated Health Program, Nigeria. From India, we have Dr. Adesh Chaturvedi, in-country team leader for the Utkrisht Impact Bond project. And from Afghanistan, we have Dr. Omar Zaman Saedi, Senior Technical Advisor and former Deputy Chief of Party of the USAID Health Sector Resiliency Project in Afghanistan. And we're very lucky to have Dr. Muhammad Asif Samsur, who is the CEO of the Afghanistan Private Hospitals Association. And we have 2 co-moderators in this morning's session. There's myself, and we have Dr. Martha Levitt, who's currently the Chief of Party of the USAID Integrated Health Program in Nigeria. So next slide, please. So here's the agenda, and I talked about it a little while ago, so I won't go through it again. You will hear each presentation. There are 4 presentations, and we will have, I hope we will have time for questions and answers from the audience. So let's begin now. Next slide, please. We will start with Susan Ray Ross, who will give an overview of the private sector engagement strategy of USAID. Over to you, Susan.
Thank you so much, Lily. Good morning, good afternoon, and good evening, wherever you may be. I'm going to talk a little bit about private sector engagement, both from USAID's perspective, but then from the broader landscape. Next slide, please. So, as many of you know, USAID launched our private sector engagement policy in 2018. One of the main reasons that we did this was that we talk a lot about the private sector, but we don't really have good definitions of who the private sector is. And we wanted to create a common language, common approaches, and a call to action to really work with the private sector. And we believe that in order to have countries progress along the journey to self-reliance, there needs to be a robust private sector. Also, it's not only USAID that's been working on private sector engagement. We know that WHO has recently come out with how to engage the private sector for universal health coverage, and they've actually been very focused on engaging the private sector during the COVID response. And I think they're, not to speak on behalf of WHO, but looking at their literature, has really stressed the need to engage the private sector as a whole of health system response to COVID. Next slide, please. So what we really want to do is understand markets. We think that markets are sustainable, and we want to be able to use the power of the market by engaging the private sector to really drive sustainability. We know that our donor dollars are very limited and that foreign direct investment is a much greater driver in terms of sustainability. And so it's important for us to understand kind of what are the demand and supply dynamics in different countries. Next slide, please. So in 2017, the Business and Sustainable Development Commission launched a report called Better Business, Better World. And the purpose of this report, in development, we often talk about the financing needs of the SDGs. But this actually looked at the growth opportunities from the SDGs if we actually achieve them. And so you can see on the left, depending on the actual modeling, it's estimated that if we achieve the SDGs, there could be an increase between $12 and $30 trillion worth of economic opportunities. And most of those, half of those opportunities would be in developing countries. They reached that number by looking at what they considered kind of 60 hot market spots. And those were along 4 different areas. So the 4 areas were food, energy, cities, health, and well-being. And within health and well-being, there are actually kind of 12 sub-markets that they thought were launched for growth. Also, underpinning this is the idea that gender parity would move us very far along, whether that's gender education, women in the workforce, and so just achieving gender parity in terms of economics could have significant financial gains. The other thing is all of these economic opportunities would create a huge opportunity and growth in jobs. So if we look at the specific health opportunities, of these, as I mentioned, of these 60 market hotspots, 12 of them are in health. And most of them are in the areas that USAID cares about. You can see on the bottom, the biggest health areas were risk pooling, telemedicine, and the areas that they actually didn't have financial projections were things like addressing counterfeit drugs, improving health worker training, and improving maternal child health. So just to say that the private sector is very interested in both SDGs and in health opportunities, and this provides an opportunity for us to be able to engage with them better. Next slide, please. So we know that the private sector is a major source of services and products. These numbers are from secondary analysis of DHS in the 25 priority countries that USAID works in, so that you can see that for maternal health, particularly in Asia, there's a large percentage of women who are actually delivering in private facilities. Similarly, for newborns, seeking care for pneumonia and diarrhea. The other thing is that we often think about only wealthy people going to the private sector. And what this analysis has shown is that 2 out of 5 caregivers that go to the private sector for child services are actually from the poor households. So the idea that the private sector is already providing a significant share of services and products is another reason that we really want to work with them. If we think about the health system, we know that in many countries there's a growing rate of or growing number of private training institutions, and how do we make sure that those actually are providing quality training and education. We know that supply chains are, many of them have many private sector partners, either at the wholesale level, at the importer level, at the transporter level. In the wash space, which was always important but has become much more important in COVID, all these, both the wash service providers and the sanitation service providers are almost all private sector, and they have a lot of private sector financing that really is important for them to be able to provide services. And then lastly, we've done a lot of work in the past doing food fortification and working with millers and different food producers to be able to make sure that we can have good nutrition. So the private sector is a key contributor to MCHN, WASH, and nutrition services. Next slide, please. So who is the private sector? As I mentioned before, one of the reasons we had the policy was to really understand who we are actually talking about. So I think we're all used to working with nonprofits and faith-based organizations. Many of them are even adopting much more market-based approaches, whether that's social franchising. We're doing a lot of work on financing with faith-based organizations right now. There are all the health organizations that we often think about, but then there are all these other private sector players that have some interest in health, even if it's not their first line of business. So whether that's banks arranging financing, whether that's telecom communications, working on digital platforms, it could be insurance companies. So there's a whole range of private sector players, and they all have different interests, they have different expertise, and they have different constraints. And so it's important for us to understand what those are so that we can best engage with them. Next slide, please. So USAID has 4 operational principles for engaging with the private sector. The first is really thinking about engaging with the private sector early and often. And I think you'll hear, particularly in the COVID presentations today, that the places where we already had relationships with the private sector, it was easy for us to continue working with them and understand how COVID was affecting their businesses and help them in that way. In places where we don't actually have a relationship with them, it's kind of hard to start a relationship during a crisis or during a pandemic. Secondly, we don't want to just engage with them in the beginning and then kind of say, okay, we checked the box and we talk to the private sector. This needs to be an ongoing process throughout our designs, our implementation, and then evaluations when we're designing new partnerships and new practices. USAID has multiple ways that we can work with the private sector. Some of them are financial and some of them are non-financial. And so really trying to understand all the different ways that we can engage with the private sector. And then lastly, we really want to build on evidence and best practices. In May 2019, we launched a private sector engagement evidence and learning plan. And so next slide, sorry. So my last slide is really talking about how we operationalize private sector engagement. We always start with some development challenge. So in this case, it's really about improving the quality of private sector services. The idea is, could there be a market-based approach to address this challenge? As I mentioned, what are the interests and the challenges that are facing the private sector? And then how could USAID actually intervene? So you will see with the presentations that are following how the different projects have been able to operationalize private sector engagement. Thanks. Back over to you, Lily.
Thanks, Susan. That was great. Thank you so much for framing the rest of the panel this morning. This lens, I love this lens framework that you have in your last slide. And I know that the other presenters will also be referring to this framework. So thank you so much. Before we move on to Nigeria, I just have one question for you, Susan. You know, I started out by saying that the private sector is largely invisible compared to the public sector in our understanding of the response to COVID. But you have been very connected with the world of the private sector. And I just wondered if you could share with us very quickly your insights on what is happening, what is the global landscape today, you know, with the private sector and their response to the COVID situation. Thanks, Susan.
Sure. So I think with everyone, it's been an evolving process. I think in the beginning, and you'll hear this in some of the presentations to follow me, that the private sector, COVID, the treatment of COVID and testing of COVID was really done by the government, even in the US. But I think as governments have understood that they are resource constrained, not only financially, but people, equipment, I think they've started to understand that they need to reach out to the private sector. I think the other thing that we've heard is that, and so we are starting to see some collaboration in countries between the public sector and the private sector, which I think is great. As I mentioned before, I think in places where they had some relationship before this, it was easier to do that. But I think, as I mentioned, you know, the private sector provides a lot of services, not COVID services, but MCHN services. And so I think they've seen similar disruptions from people just being afraid to go to the facilities like the public sector has. So I think I don't want to take up the time from the other countries because I think they can probably answer this better than I can. But I'm really looking forward to the presentation. So handing it back over to you.
Thank you. Great. Yeah, let's dive right into the country presentations now. And I'm going to hand it over to my co-moderator, Marta Levitt, who will moderate the session, the presentation on Nigeria. Thanks.
Marta, you'll need to unmute, please.
This will help. Sorry. Good afternoon, good evening, everyone. We're going to do a presentation from Nigeria, and we have Dr. Mukadis, who is going to start off the presentation. We're going to talk about COVID-19, how it affected public health services, and then go into description of resurgence recovery and how the private sector can help. Dr. Mukadis?
Hello, everyone. So my colleague Funke and I are going to present on adaptation, resurgence, and recovery of primary healthcare services in Nigeria during COVID-19 and beyond. The focus states which we are going to discuss is Bauchi State, as shown in the slide. Next slide. So during the Integrated Health Project is a flagship service delivery project that is funded by USAID Nigeria. It started in 2017 and will come to a completion in 2024. It supports federal level activity as well as 4 other states in Nigeria, as well as the Federal Capital Territory. The focus state, Bauchi State, has a population of over 7 million people, and IHP supports more than 1,000 different healthcare facilities through an integrated approach focusing on maternal health, reproductive health, newborn child health, nutrition, and malaria through provision of technical assistance and capacity building, rapid scale-up of high-impact intervention, bringing on new innovations, and also supporting sustainability and country ownership. Next slide. So during the COVID pandemic in Bauchi State, the goal of the project is to strengthen the state level reduction in child and maternal morbidity and mortality and increase the capacity of health system, both public and private, to sustainably support quality primary healthcare services through 3 very important objectives. to strengthen that health system to support primary healthcare services and improve access and increase quality of primary healthcare services. Next slide. So in both states during the pandemic, next slide, the first confirmed case was discovered barely a month after the case in Nigeria, and that was in March 2020. And Bauchi State contributed over 700 confirmed cases to the data with 14 dead. There were upsurge of cases that occurred in the month of April and May, where 176 cases were confirmed positive. These were in 4 local governments that bordered another state, which is Kano State. And there were 2 lockdowns in the states, which they stated the executive governor to pronounce the lockdown following upsurge of cases, 2 upsurge of cases as depicted in the graph, where a lot of cases, 69 initially, were in the second instance and 44 in the first instance were confirmed positive. And this could be due to the intensive testing through the 2 new testing laboratories that were open in May and June in the state. Next slide. So what happened to healthcare services during this pandemic? It's of note that leadership of state and federal diverted their attention to the COVID-19 response, and also funding was diverted from the routine primary healthcare services. This, of course, impacted on healthcare services like the outreach services that is usually conducted, campaign for immunization, maternal and child health, and also there was reduced client health seeking behavior at primary healthcare centers, despite the fact that the primary healthcare centers stayed open. IHP rapidly supported the state to initiate training in infection prevention, especially and washing and decontamination, as well as supported training on the COVID response to ensure that primary healthcare providers were trained to prevent the community infection of with COVID. And there was also support for the state to address the challenges with provision of personal protective equipment, as well as the growing fear, misconception, and stigma associated with COVID-19. Next slide. So IHP supported all this training, and there were a lot of adaptation because the usual training could not happen on a physical, next slide, in a physical way. So what IHP did was to develop means of training through remotely through innovative approach using available mobile technology like the platform of WhatsApp, where 372 primary health centers across 37 local governments in 3 states of Bauchi, Kebbi, and Sokoto were trained on different aspects and also mentored and supervised remotely. As is shown in this diagram, these are just snapshots of conversations and trainings between IHP staff, local government staff, and service healthcare providers. Next slide. So other things that healthcare providers are trained were also on documentation and reporting of healthcare services. This is a screenshot of conversation between a local government M&E officer and a IHP data analyst. Next slide. So these are all the various innovations that were put in place to ensure that service continue. Next slide. So what happened to the healthcare services uptake during the pandemic? Just as happened in other nations, in Bauchi State, there was decrease in a lot of service delivery at health facility. Regress up to now that has not come up. Outpatient visits also sharply dropped, but that has recovered significantly. Reporting rate, there was minimal reduction because of the continuous mentoring that healthcare service providers were given. So it has since recovered significantly. So next slide. So different services were affected in different ways. However, with the ease on lockdown, there was recovery from a lot of the effect of the pandemic. Next slide. We supported the state to come back to work and fully recovered in terms of providing quality healthcare services, in terms of integrated supported supervision, provision of also continued mentoring, provision of equipment and training models, and work has resumed fully in that state following IHP support. Next slide. So let's look at the next slide. So let's look at what are the lessons learned. The lesson learned is that during the pandemic, we were able to stay connected with the local government and primary healthcare staff through interactive social media like WhatsApp, through the use of mobile technology, and through all the various platforms to ensure that workers stay motivated and continue to work and improve data recording and reporting. It was also clear and with a clear and well thought out COVID-19 business continuity plan, this enabled IHP and the government to make a rapid transition to an enhanced way of working remotely while effectively protecting staff from the risk of infection, especially with COVID-19. And we know that now the resurgence and recovery and building a resilient system cannot be done by government alone. This will require partnership with traditional and religious leaders, civil society, and the private sector. Okay.
Thank you, Dr. Halima. Next slide, please. Good afternoon, everybody, and good morning, depending on which part of the world you're in. I'm going to be talking about IHP's private sector work in Bauchi, where we just completed a landscaping assessment to determine the readiness of the private sector to provide quality primary healthcare services, and to also identify any impediments, any barriers, impeding their participation in the primary healthcare system. The assessment involved 47 healthcare facilities, 19 community pharmacies, and 201 PPMVs. As Susan had mentioned previously, the private health sector is a key provider of health services in development countries, and Nigeria, and specifically Bauchi State, is no different. If you look at the graph on the screen, you will see that client traffic for malaria testing on the average per month in each private facility was about 500 clients, about 400 for immunization, and about 160 clients for malaria treatment. We found out that antenatal care and deliveries were the most frequently offered services across the different private health facilities, while immunization and nutrition services were the least offered services across the private health facilities. We also saw that some private facilities report data into the National Health Management Information System, and it was interesting that this was done using government-provided registers, but usually submitted through development partners who presumably offer some support for training and provision of medicines. Interestingly, we found that most facilities kept patient records, but only 4 out of those we surveyed kept extensive data on service utilization for their own use and decision making. Next slide, please. Some of the other findings of note during the assessment were that government regulation of the private health sector is quite weak. For example, we were unable to cite any documentation on the process for registration or inspection of facilities, except for a 1986 law. We also found that the registration unit in the State Ministry of Health is incapacitated in terms of personnel. There's only 1 full-time staff. And also in terms of the resources that are required to carry out regular inspections. We saw that on the average, each private health facility had about 2.4 doctors and about 20 healthcare workers in total. This is in stark contrast to the public health system, where we see that the largest cadre of health workers at the PHCs are the community health workers, and where there is an average of 3 to 4 health workers per primary healthcare facility. We also noted that all facility categories experience frequent stockouts, and some of the commonly stocked out commodities and medicines that were reported were long-lasting insecticidal nets, amoxicillin, malaria RDTs, chlorhexidine, oxytocin, and magnesium sulfate. And this is likely to be due to a mix of factors that are related to ineffective inventory management and limited working capital to restock commodities as they go out of stock. About a third of the private facility owners that we spoke to had formal business management training. However, only few kept comprehensive financial records. We noted that there seemed to be a general aversion towards seeking financing, and only 9 of the facilities we spoke to had ever sought a loan. We also noted limited efforts for public-private engagement and collaboration in health in Bauchi State. The government developed a 5-year strategic health development plan that is supposed to end in 2022 and mentioned leveraging the private sector, but there has been little or no follow-through on this. We also found out that there was a public-private partnership desk located in the governor's office, but this is not focused on any specific industry, and the only collaborations that have happened in the past have been in extractives and agriculture. Next slide, please. So from our assessment, we know that there are several, impediments or barriers limiting the participation of the private healthcare sector in the total health system. However, we still think that, they are very integral to ensuring that we build the primary healthcare system. And we think that this will come from a collaboration of both the public and the private sectors. Based on the responses we got from the landscape assessment, we know that the private sector is primarily looking for growth. And this is growth in terms of market share, growth in terms of earnings, and they're also looking for any cost or process efficiencies that can lead to overall increase in return on investment. We also found that some of the barriers to achieving these for the private sector are the lack of government policies to facilitate an enabling environment for investment, poor access to continuing clinical training, suboptimal management systems on the part of the private health system for making operational, financial, and strategic decisions, and of course, limited access to financing. Next slide, please. So some of the short to medium term interventions that IHP will be focusing on to alleviate some of these barriers are to develop a private sector engagement strategy and plan, which will set a roadmap for improved private sector regulatory and registration systems. Others include training of private sector providers to improve quality, linking them with financial institutions to access loans, and accrediting private sector facilities in social health protection schemes that are kickstarting in Nigeria. Next slide, please. So going back to COVID, there were some good practices that we saw both in the public and private health sectors that we think will continue beyond COVID. Some of those are the efficiencies gained from virtual meetings and from remote mentoring and supervision, as Dr. Halima had presented. We also think that we'll begin to see improved infection prevention attitudes and practices, and this will largely be driven by increased client awareness and demand. Finally, we expect to see increased use of technology in the supply of health services through mobile solutions such as audio job aids, M-curricula, and client feedback hotlines that ride on private telecommunications networks. Thank you. So I'll now hand it over to Martha to continue the moderation of this session.
Hi, folks. I'm looking at the attendee list. It looks like Marta was kicked offline just for a moment. So sorry about that. That's why we have in our opening announcements just to hang with us if we have any technological challenges. I'm just going to zip over to see if there's anything we can do to help her get back connected.
Bethany, I'm just wondering whether we should just start the next country and have Marta continue with Nigeria after, maybe after the two country presentations.
I'm seeing her, she's trying to log back in now. So thank you, Lily. I'm gonna give her 30 seconds to see if we can get her back online because I see her now. Marta, if you can hear us, you have the floor, and otherwise we can do our plan B. Okay, Lily, let's go back over to you, and we can pick up when Marta's back. Thank you.
Okay, yeah, I think we should just jump right into the India presentation because that was scheduled to be the next presentation. Let's move on into that, and then Adesh, when you're done, we'll have Afghanistan, and then we can have the Q&A, and that's when Marta can continue her questions for the Nigeria team. Thanks, Adesh, over to you.
Thank you, Lily. Good morning, good afternoon, and good evening. So I would like to share our experience on, how we layered in COVID-19 intervention when we were implementing development impact bond, the Utkish development impact bond, which is the world arguably first impact bond on maternal and newborn healthcare services with the private health sector. Next, please. So here I would like to share, I know many of you must be knowing much about, impact bond and all, but for the, benefit of the other participants, I would like to, mention and share the a few information about Utkish impact bond. Next slide, please. Next. So how does development impact bond work? So basically, a private investor provide working capital for a set of interventions and are repaid with a return by outcome funders if pre-agreed results are achieved. So this, diagram, so there is an investor who provide upfront working capital for implementing the project by to the field agency through the implementation manager. And when the field agency and the implementation manager execute that activity and get the outcomes, then those outcomes are verified by the third party verification agency, usually hired by the outcome payers. And then on the successful recommendation of the verification agency, the outcome payment return the capital plus interest money to the investors. So here this is the important aspect, and the role of implementation manager also become very important to provide hand-holding support, strategic support, and also establish a greater communication between all these partners for the effective implementation of the DIP. Next, please. So as I was mentioning that here the outcome funders like USAID and Merck for Mother in this case have shifted their risk from input to outcome, so that they are just concerned towards the outcome. Next, please. So I would like to share the institutional mechanism to make you more familiar about DIB. So as I mentioned that we have two outcome funders, MSD for Mothers and USAID. And we have two implementing agency, two field agency like Hindustan Latex Family Planning Promotion Trust, HLFPPT, and Population Services International, PSI. And Palladium is the implementation manager. Here the big investor is the UBS Optimus Foundation, United Bank of Switzerland's Optimus Foundation. And Palladium, HLFPPT, and PSI are also the co-investor here. So basically the total outlay of the project is $8 million plus $1 million is for the verification thing, and the duration is 3 years. So we expect that we have the 360 private healthcare organizations to whom we have to improve the quality of these private healthcare organization. The base case is 360, and approximately 600,000 pregnant women would be impacted, and we would be able to save at least 10,000 lives during this 5-year of period, 3 years plus 2 years implementation. Next. Here I would like to mention one important player. Please come back to the slide, where government is a non-executive partner here. Government is not a regular partner of this Utkish, but government has played a very important role when it comes to schemes and policy. If they have a favorable policy towards the private sector, the success of any program increases a lot. Next, please. So I would like to share what challenges Utkrisht DIB had when it started, and also we found the similar challenges when pandemic hit the program. So basically, improvement of quality of services was not the priority of the private small healthcare organization. A small healthcare organization has a varied canvas, so they have limited resources and they have to run their facilities without any outside support. And also they have very less idea that what all how the quality improvement would help them, would benefit them in the long term. So they have less idea about investing on the quality improvement thing. And then there is nobody to help them out, to guide them, to provide handholding support in to make them to the journey of quality improvement. And of course there is a government and private sectors work in a silo, so there is disconnect. So there is no such policy related inputs and all. So here we have also seen the same thing, the similar challenges when COVID hit to the project. Here I would like to clarify two things. The small healthcare organizations are not that small which you are thinking. It is, as per the Quality Council of India's definition, it is up to 100 bedded facilities. And Utkrisht is working with those SHCOs who have at least 10 deliveries per month, less than 100 bedded facility, and having the cesarean and neonatal care services. Next, please. So what we do, we support for the facilities to prepare for accreditation under two schemes: National Accreditation Board of Hospitals (NABH) and FOXI-led Manyata program. So we map the facility, we do the baseline based on the criteria, we engage them early, we take them on board by sharing the baseline analysis, we sign the MOU, and we start the quality work like training, handholding support, monitoring, data management, and all those things, and the facility get ready for the preparation. So this cycle takes 6 months. Next, and we also extend our support to the graduated facilities. Next, please. I spoke about two accreditation. One is Manyata and one is national. One is NABH. So Manyata, basically, this is the initiative of Federation of Obstetric and Gynecology Society of India, who are basically there to ensure all pregnant and lactating women should receive respectful quality maternity care. And NABH is a bigger, larger comprehensive initiative of Quality Council of India to ensure overall quality improvement of the hospital and patient safety. Next, please. So we were basically, under Utkrisht, our mandate was to prepare the facility for all the 10 chapter, up to 50% level of all the 10 chapters of NABH and 70% of the FOXI standards. But here, realizing the importance of quality, Team Utkrisht has gone beyond the payment outcome metrics and supported SHCOs for actual Manyata certification and NABH accreditation. Next, please. So we are working in Rajasthan, and our base case is 360. Currently 344 facilities we are working with, and we have touched around more than 200,000 deliveries. And as I mentioned, the Team Utkrisht has gone beyond the contractual obligation, wherein out of 344, 322 facilities have received actual Manyata certification, and 51 facilities have received NABH, and 150 facilities have applied for NABH. Next, please. So if you see the facility, just this will speak by itself, the before and after. Next, please. So I would like to share how we did during Utkrisht. Next, please. During the COVID-19. So due to COVID-19 and related lockdown, the SHCOs were closed. The services were restricted, and there was a atmosphere of uncertainty. Private healthcare facilities were in a state of confusion as they were not getting the clarity on the government's guideline nor clinical or managerial protocol. And guidelines were changing rapidly as the new information emerged, and the protocol underwent quick improvisation, adding to the confusion and uncertainty. So there was nobody to extend their support to the private healthcare facilities. Next, please. So in that case, how we responded? So here the challenge was in front of us was improving the quality care and maintaining and improving the quality care of the private health sector during COVID-19. So there were 5 questions. We asked that, can private sector do it itself? Answer was no. Then the Utkrisht, MSD for mothers and USAID supported Utkrisht program came into the picture. We extended our support to the private facilities for maintaining and improving the quality care. Next. So our team considered Utkrisht as an opportunity to support SHCOs, and we initiated online training program to the SHCOs, and we have conducted more than 6,000 training program, not only on NABH and Manyata, but also on Utkrisht. More than 2,000 programs were on COVID-19 particularly, and we were not having any standardized module on for online training. We were having it on-site, but we have converted all those things into online, and we implemented those things, and we have done close monitoring and the data analysis for rapid mid-course correction, so that we can serve the hospitals in a more effective manner and quickly. Next, please. So we also worked with the government. We worked as bridge, and we also approached to our investor UBS Optimus Foundation, and we started go beyond our mandate, and we started the touchless maternal and newborn child health services in the form of telecounseling and telemedicine for the pregnant and lactating women who were not able to reach the hospital, and there was also risk at the hospital for getting COVID infection. Next, please. So these are the smiling faces of online training. Next, please. And these are the appreciations which we got from the hospitals. Next, please. Next. So I would like to share the learning part and the way forward. Next, please. So COVID-19 forced us to innovate and respond quickly to a critical national and global priority. The DIB model, by virtue of its contractual focus on deliverable outcomes, provided complete flexibility to go beyond the budget line and deal with pandemic by leveraging existing Utkrisht resources without posing any administrative burden on the outcome funders. And the investors decided to minimize their losses instead of maximize the revenue. So and also we have learned that quality is not easy thing to establish, maintain, and sustain. So early engagement and continuous support with and for the private sector to collaborate with and complement the public sector are critical for a holistic system approach. Build on the in-principle buy-in by SHCOs on rigorous monitoring, microplanning, and gap analysis using data, which allows for targeted management for improvement. And we would like to advocate that the sustainability should be seen from the different point of view, not from the financial point of view. So sustainability of private sector engagement to be seen from the reputational, recognition, and reliable point of view. If a facility reaches to a level where it gets the quality accreditation of Manyata and NABH, then the reputation of the facility is attached to the quality assurance certification. So they have a reputation in the fraternity, in the peers, in the periphery. They have been recognized by its quality. So it's really difficult for the hospitals to come back to the less quality services, no matter how much resources they have to put in from their own. So this is the sustainable model of quality improvement. Next, please. Now I would like to share the way forward. So what is way forward? The pandemic taught us the importance and utility of touchless services and intervention, touchless training, online training, touchless monitoring, touchless mentoring, online telemedicine, telecounseling, and all those things, monitoring, also assessment. So all those things have gone from on-site to online, and I think this is the future in the near healthcare system strengthening. Importance of facilitator organizations like us, like Utkrisht, played an important role to work with work as a bridge between private and public sector needs to be encouraged. Role of private health sector needs to be recognized, and greater involvement could be explored during the pandemic and emergency. Quality improvement during the pandemic, which we have seen particularly focused on infection prevention and control, has proved to be one of the most important aspects of healthcare services which would gain immense attention. And DIB model, by virtue of its uniqueness and credibility during the pandemic, not only run the project efficiently, but also address the larger issue of COVID-19. Next, please. I would like to thanks to USAID, DC team, Lily and Suzanne and all, and my Palladium team. And also this is a beautiful team members of Utkrisht, the team members of HLFPPT and PSI. I would like to convey my thanks. And also I would like to mention one name of Gautam Chakravarti, who is from the India mission, and supporting us on and off on this Utkrisht program immensely. And also, last but not the least, I would like to thank the SFCOs. Without their positive involvement, the success of Utkrisht cannot be considered. Thanks a lot.
Dr. Omar, would you like to go right away? Thank you.
Sure. Thank you. Good morning and good afternoon to everyone. My presentation is about the private health sector engagement activities under the USAID Health Sector Resiliency Project in Afghanistan, especially in the context of COVID-19. The CEO of Afghanistan Private Hospital Association will co-present with me a few slides. Next slide, please. The HSR project was a USAID-funded 5-year project. It started on September 28, 2015, and ended last month on September 27th. The project had 3 main components, and the private health sector development was a key focus area. Next slide, please. So why private health sector development is important? In Afghanistan, the private for-profit health sector or commercial market plays an important role in delivery of health services and products. The national health accounts estimate that more than $1 billion is spent in the private health sector annually, and of this, around 285 million USD is spent abroad by patients seeking care, quality care, especially in the neighboring countries. Almost all this money that is spent by households are out of pocket and at the point of services delivery because the health insurance is not in place in Afghanistan. In this context, the quality of private health sector services and products is perceived to be low. And of course, there continues to be limited availability of services for consumers inside the country. And ineffective regulation is also considered one of the key challenges. So again, why is it important? The private health sector is important because it's already here, as I mentioned. So it needs to improve quality and support the national health objectives. Next slide, please. To better understand the profile of the private health sector and to generate data for planning and policy making, we conducted a private health sector assessment in 2018 in 5 major provinces in Afghanistan. We mapped more than 6,000 kilometers of streets and identified almost 14,000 private medical facilities. We also conducted quantitative survey and also key informant interviews. We also created an interactive dashboard, as we see here on the screen, to enable the Ministry of Public Health in the private health sector to better utilize the data from the assessment. Next slide, please. I have highlighted some of the key findings here related to the curative services. The assessment found that the private health sector is bigger than what was believed. As we see here in the diagram, in terms of the number of private hospitals and clinics, in all Afghanistan, private hospitals constitute 71% of the total facilities. And just in Kabul, 87% of the curative facilities are private in terms of the number. But facilities with advanced services are exceptions. They are not the norm. On average, the private hospitals are rather small, The bed occupancy rate is actually low, and it is 4 times less than the recommended level, which shows that there is excess capacity that can be utilized for expansion of essential services. People visit private facilities because they believe that the private facilities provide better services, while people prefer to visit public facilities because the services are cheaper. In terms of the gender composition, 25% of doctors are female, which seems to be low and which may affect services for women in the private health sector. Next slide, please. As we see, from the findings that private sector also provides advanced services. Some of this may not be available in the public sector, although they are still limited. We also see that the private health sector provides reproductive, maternal, and childcare services as well. We see here in this diagram from the private sector assessment that 46% of private hospitals provide gynecology services. Next slide, please. USAID Afghanistan Services Provision Assessment, or SPA, also confirms that the private health facilities play an important role in the provision of basic MNCH services in Afghanistan. As we see here, in the highlighted row, in yellow, almost 80% of private facilities provide childcare, and approximately 72% provide modern methods of family planning. Next slide, please. These are some of the policy level recommendations that we provided to the Ministry of Public Health for better engagement of the private health sector. Next slide, please. In the next few slides, I will talk about the private sector engagement. Of course, the CEO of Private Hospital Association will co-present with me in response to COVID-19 and also HSR support in this area. Next slide, please. The first COVID-19 case was confirmed in Afghanistan on February 24th, and it rapidly spread across the country. Although the number of new cases declined considerably in August, private sector was allowed to provide COVID-19 testing and cases management in June 2020. As of now, around 13 private facilities in Kabul provide COVID-19 testing, and many other private hospitals in Kabul and in provinces have the ability and are ready to provide cases management as needed. Next slide, please. So in terms of the HSR support in response to COVID-19, the private health sector assessment that I mentioned just before in the previous slides, this assessment guided the Ministry of Public Health and other stakeholders to identify the location, the capacity, and the type of the services that they provide. In this way, the government and the ministry was able to better decide, how to engage and if they would like to engage the private health sector in response to COVID-19. We also supported the Ministry of Public Health to identify various strategies for private health sector engagement through development of a concept note. And also we costed the COVID-19 cases management so that we help the ministry in case they want to purchase services from private for-profit or from NGO sector. And also through engagement of VIAMO, which is an international organization specializing in using mobile technology for trainings. We trained around 630 health providers, including doctors, nurses, midwives, pharmacists, and lab technicians through mobile phone technology. Next slide, please. Now I would like to pass it to my co-presenter, Dr. Muhammad Asif Samsur, who is the CEO of Afghanistan Private Hospital Association, and he will provide his perspective on COVID-19 response of private health sector and some of the quality improvement initiatives. Dr. Asif Samsur, please.
Please remember to unmute. We can't hear you.
Dr. Asif, we can't hear you. Please unmute yourself.
Can you hear me now?
Yes.
Yes, perfect.
Perfect. Thank you.
Thank you. Good morning, good afternoon, and good evening, everyone. First of all, I would like to thank you for this opportunity to talk about our collaboration and joint effort with the Ministry of Public Health and the USAID STAR project over the years to improve quality and the standards in private hospitals and clinics. Afghanistan Private Hospitals Association is a business membership organization, and we have around 120 hospitals and clinics in Kabul and 346 hospitals and clinics in provinces as our members. Development of minimum required standards and its implementation has been a joint initiative between the Ministry of Public Health, the Afghanistan Private Hospital Association, and the HSR project. Implementation of these standards helped our hospitals and clinics to identify gaps in our services and improve our quality. Because of implementation of these standards, when COVID-19 started, we had the basic measure in place at our facilities for prevention of COVID-19. We provide these services. Prior to start of COVID-19, jointly with the aim of Ministry of Public Health and the HSR project, we had implemented MRS in 200 hospitals and clinics in Kabul and provinces of Afghanistan. And after COVID-19, we have implemented the MRS in more than 20 hospitals and clinics. MRS is a good tool for us because our members can implement it themselves and identify and improve their gaps. All of our members' hospitals and clinics have received MRS training and implement the standards in their facilities. Next slide, please. Thank you. This is the MRS dashboard that shows the strengths and gaps in services delivery at private health facilities. After the gaps are identified, our association works with the member hospitals to fill the gaps and improve their quality. As we can see in this slide, the MRS have 5 domains. We also have standards for reproductive health, neonatal and child health, and MRS checklist. This is the end of my part. Thank you for your attention. If you have any question, I'm happy to take and provide more information. Thank you.
Thank you very much, Dr. Samsur. So next slide, please. So beyond COVID-19, particularly in relation to provision of MNCH services through the private health sector, a key challenge is how to maintain and increase access to quality MNCH services. If we apply this structured approach of USAID for private sector engagement, we can conclude that for achieving the goal of expanding MNCH services in the future through the private health sector, the private commercial market is certainly part of the solution. They can do a lot to achieve this goal, but private sector actually cannot do it alone. There are certain challenges that would constrain the private health sector from achieving this goal, including, for example, lack of the proper stewardship by the government, lack of incentives, and so on. So these barriers needs to be addressed actually in order to be able to expand these services in the future, and USAID can play an important role in supporting governments in achieving this goal. Next slide, please. So finally, on what we have learned from COVID-19 and how this would shape future of private health sector engagement. First of all, COVID-19 affirmed that the important role that the private health sector can play in achieving the national health goals. We also learned that the private health sector development should be a continuous in a priority agenda. So the private sector is prepared to serve effectively alongside the public sector, especially in emergency cases and in time of emergencies and needs such as the COVID-19. Also, I think it is the time that the governments, especially in Afghanistan, start to purchase services from the private for-profit or commercial market. This will improve capacity of private for-profit health sector, including capacity development of the providers, like doctors, nurses, and midwives that work in these facilities. And finally, supporting the private health sector in record keeping, reporting, and harmonized reporting, what we call, aligned with the public sector reporting, will help better plan, and especially in planning and in policy making for private health sector engagement and health sector policy making in general at the national level. So with that, I come to an end of my presentation. If I'm happy to take any questions next. Thank you very much.
Thank you, Dr. Omar. That was an excellent presentation. So thank you so much. And I think we've completed the presentations from the countries, and I would like to move into the Q&A part of the panel. And I think it would be good to see the faces of all the presenters, if possible. And if the internet connection, starts getting a little anxious about that, I think we'll have to turn off our internet and just, the person who's speaking can turn it on. For now, let's take a risk and have everyone on their video. Wonderful. Okay. Dr. Adesh, you had mentioned that there will be 2 private sector doctors. Are they with us? I can't see them on my screen.
I believe they are with us. Dr. Dhananjay, if you could switch on your video and mic also. Dr. Dhananjay?
Yeah, very good evening. I'm here, Doc.
Wonderful. So since I had not introduced Dr. Dhananjay, let me just mention to the audience that Dr. Dhananjay Mangal and Dr. Madhu Mangal are a husband and wife couple. I'm so excited about that. And Dr. Dhananjay Mangal is the pediatrician, and Dr. Madhu Mangal is the OB/GYN, and they have one of the clinics that's participating in the Utkrisht project. So really wonderful to have you here. I really wanted to hear voices from the private sector, from the health providers. So we're so happy you've joined us. So, so let me actually begin, since I just introduced you, the 2, Dr. Mangal. If you could just, let's start with you. So I would really like to know why you joined the Utkrisht project. How did it help your business? Dr. Adesh had mentioned that it was very hard to work with the private sector providers because quality of care wasn't such a huge priority. But I want to hear from you yourself. Was it not a priority? Isn't improving quality of care good for your business? So tell us why you joined the Utkrisht Bond project and how did it help your business? Yeah, over to you.
Thank you very much for giving me an opportunity to be here. And with the quick response, I would go to the question directly to the answer. So why I joined this Utkrisht project? So I am a pediatrician. I'm working for last 24 years. Since then, I had started a very small clinic. From there, now we are running a 50-bedded exclusive pediatric and neonatal hospital along with the gynae. Okay. So during this journey, I realized a lot of work we did, but having so many problems in spite of doing a lot of work. So by improving the quality, we heard about the Utkrisht through my friend. So just to improve the quality, they have given us so many support in terms of the training and how to maintain the protocols, guidelines. So by within a year after association with the Utkarsh, so we got a lot of improvement. Though we were in large prior also, but after that, so without hassle, protocol based, very systematized, with good positive waves in the hospital. So this is the things which gives us a business also, as well as a satisfaction to the patient, attendants, and my staff. So that is a very good thing. So with this training and this data analysis, so we are planning to go in data analysis. How can we improve our clinical services? So that is the things why this we joined this Utkarsh, right? And one thing I would mention here, I am a president of the National Neonatology Forum in the Rajasthan State Chapter. So we are working for last 7 years in a field of neonatology, especially in the neonatal intensive care units. So we are planning to introduce some Garb Grah project. It's a sort of like a mother bomb care, particularly adaptation care. So in the area where only 5-10 bedded nursery, five bedded nursery homes.
I'm not sure. I think he froze.
We lost your voice, Dr. Dhananjay, and I think there is some connectivity issue. So Lily, you can,
Yeah, let me move on to another. Yeah, I would like to move to Afghanistan and ask a question for Dr. Asif, because I'm very excited about the private sector. So my first questions are for the private sector. So Dr. Asif, as the CEO of the Afghanistan Private Hospitals Association, you're playing a very, very important role. So pleased to have you here. And in that role, you probably have a very good sense of what's happening nationally in the private sector. So my question to you is that most countries have experienced disruption of essential maternal, newborn, and child health services as a result of the pandemic. And I'd really like to hear from you on what's happening in Afghanistan. Has there been a disruption of services and commodities in the private sector? And how has the private sector responded to this situation? And has it affected the quality of services? Thank you.
Thank you very much. Yes, there were disruptions in services when COVID-19 started in Afghanistan. All of the services, including the MNCH services, were disrupted. Some of the private hospitals didn't have patients or even closed their doors, as the government didn't allow them in the beginning to provide testing and treatment services. Now all of the services, including the MNCH, has been restored in private sector. The Ministry of Public Health allowed private hospitals to provide COVID-19 cases management and testing in June 2020. As of now, 9 labs and 4 private hospitals provide COVID-19 testing in Kabul, and many of our private hospitals around the country are ready for providing COVID-19 cases management. The number of COVID-19 new cases have reduced a lot, but if the cases go up again, our private hospitals are ready to support Ministry of Public Health and contribute to response of COVID-19. I hope you answered the question.
Thank you so much. I'm just wondering whether Marta is back online. No. Okay, so we'll just continue and hopefully she'll join us before we end at 10:30. So let me then ask Dr. Omar the next question again, it's for Afghanistan. You know, private sector information system is always a challenge in most countries. The private sector does not like to report on their data for various reasons. They don't like to report it to the government. So I just wanted to hear from you on the system in Afghanistan and how you're addressing this challenge.
Thank you very much. Very good question. Actually, we in Afghanistan, we under the previous USAID project, health policy project, we worked together with the Ministry of Public Health and also the Private Hospital Association to pilot a reporting system from the for-profit hospitals to the Ministry of Public Health. And this pilot actually implemented for 6 months. And I will just outline some of the learnings from that pilot. First of all, private hospitals are more comfortable to report to their association because they consider the data that they provide as sensitive data. I don't know. I mean, this is more because this is private sector, you know, they consider it somehow sensitive from various perspectives. So the private hospital association is in a better position to collect data from its member hospitals, compile this data, and then submit it to the Ministry of Public Health in aggregate. And disease of emergency importance can be directly reported to the Ministry of Public Health, given the geography is important for notifiable diseases. But for general services, I think the best way is that if the Ministry of Public Health allows the private hospital association that they collect this data, and this way the reporting, compliance will increase, the quality data will increase because the private hospitals will not be will be more compliant with the reporting. So that was one of the lessons. The second was that we must utilize simple to use software and have the reporting online and less burdensome for the private sector. So this way, in the pilot, actually at that time we used the DHIS2 system, and it worked very well because many hospitals nowadays they have access to internet. And it was easy to use, and we trained, of course, the private hospitals about this. And third, we should use only priority indicators for the reporting. We shouldn't, come up with so many indicators that there will be a burden on the private sector and also make it costly for the private hospitals. Because ultimately, the for-profit sector will shift any cost to the patients ultimately because they're for profit. So it's better that we make it less costly, and with that, like only priority indicators, and this will work actually. And we hope that the lessons of these reporting system that we have piloted, that the Ministry of Public Health and the Private Hospital Association will utilize some of these, and I'm sure that there is much interest nowadays, and this will go on to the next stage. Thank you very much.
Thank you, Dr. Omar. You're so right that the system has to be simple in order for it to work. Let me ask a question to Dr. Adesh, and then after that, I believe Marta is back online and could follow up with the Nigeria question. So, Dr. Adesh, I find the development impact bond a very, very interesting model, and it seems to be working in India. So once that ends, it's still a project, although the Rajasthan government, I understand, has been very, very engaged in it. But once that project ends, to support a greater involvement of the state government in engaging the private sector, what is the potential for a longer-term development impact bond or other performance-based financing once this project ends?
It's a very burning and pertinent question, Lily, and I usually face this question on and off, and answer is very difficult actually. From development impact bond to social impact bond, it's, it is too early to comment on this, as government has its, commitment for the public facilities. However, government through its policies and programs make the environment favorable for the private sector to establish the, quality as an essential and mandatory requirement. So if government has a favorable policy towards, quality improvement, and like, through their policy, through their, schemes and all, insurance scheme, there are a lot of potential on, implementing similar development impact bond, and also there are various ways to connect it with the government. And I'm quite, hopeful. If we have the opportunity, we would like to definitely go beyond this Utkrisht impact bond, and also take the government on board as not always as a non-executive partner, but also as an active partner. Here I would also, mention that I would rather advocate to create a market pressure for people to avail the quality services, and develop a revenue model for the hospitals, particularly larger hospital, where the SHCO can, or the private sector can provide support for quality initiatives to get a quality assurance process. So there is immense scope, as you asked.
Thank you so much. There's so many questions I have, but I think we need to move to Nigeria. Martha, are you on?
She seems to be with us, Lily, but not able to unmute herself for now. There's still some challenges with the tech. So how about we, do we want to keep moving?
I do have Martha's questions. So let me ask one of them at least, or if not, maybe two questions for the Nigeria team. And either Halima or Olufunke could respond. What should be the top two priorities to engage the private sector in the recovery and resurgence of primary healthcare services? Either one of you can respond.
Thank you, Lily. Perhaps I'll go first, and if Dr. Halima has something to say, she can add on. So I would say that going forward, one critical intervention for me will be the accreditation of private health facilities into the social health protection schemes. And I had mentioned that briefly during the IHP presentation on involving the private sector in the health system. And the reason why this is so important is because in addition to increasing the availability of services, MNCH services for those providers, for those areas where providers are enrolled into the scheme, it also provides an incentive for quality improvement and healthy competition. Because if you are in a pool of providers, whether public or private, and you are being paid based on the number of clients or enrollees that are coming to, there's going to be a shakeout of those who provide low quality, and there's going to be effective competition, to make sure that people are able to grab the larger part of the market share. Also, I think that linking private providers to social health protection schemes may be the last piece of the puzzle, for ensuring that we improve financial access to these providers, because enrollment in the accreditation into these schemes ensure that it provides evidence of assured client flow through the enrolled beneficiaries, whether through capitation or case-based or fee for service. If you can show some kind of historical flow of paying clients that go through your hospital or through your clinic, then it's possible that you will improve your bankability, and you'll be better able to approach financial institutions to be able to take on facilities to expand your services. And I just wanted to make the point before I hand it off to Dr. Halima that when I say social protection schemes, there are two major schemes that are taking off in Nigeria now. They are the state health insurance schemes. There are going to be 36 plus 1 state health insurance schemes in each of the states in Nigeria. Then there's the federal government health insurance scheme, which is known as the basic care program. And inclusion of the private sector in both these schemes is really going to be pivotal to integrating the private sector into the overall health system, in my view. Thank you.
Thank you so much. Halima, do you have anything to add? Otherwise, I have another question for you. Okay, I'll go ahead and ask you the other question, and that is, how can we better leverage the private sector during the pandemic and beyond the pandemic, including the private health sector and the private non-health sector?
So we have seen the difference, how the different sector and multiple stakeholders contributed towards the recovery from the pandemic. And from our presentations, we have seen the contributions of the private sector to healthcare provision. We can leverage these sectors in pandemic preparedness, involve the thousands and different organizations and millions of professionals and volunteers workers. Through institutionalization of the private sector into national health programs, like Funke has mentioned, the health insurance program. We also have other programs that are not directly health, but they also impact on health, like our nutrition program. We have education program, especially pre-service education, that will provide the needed manpower. Private sector can be made part of the national health system. We also need to put in place strong institutional platform to foster public-private partnership that will deliver critical innovation for health. This will come across the sector, whether health or non-health. We also have to set up system and policies to formally recognize private sector contribution, especially in the state. Make sure they are included in the state strategic health development plan and other plan that comes up in the state. Let them be part of it. That will go a long way in ensuring that, yes, the private sector is contributing to the health, whether during epidemics or during beyond pandemics.
Thank you so much. Maybe I should end with one last question for Susan. Susan, you've heard these fantastic presentations, and there are these experts sitting right here. And I just wondered whether how you feel about those programs now sort of being framed, the lens that you had provided earlier. Do you think that these programs have really sort of responded with market-based approaches as you envisioned in the conceptual framework? And is there anything that that USAID needs to do more of in order to support this effort in the private sector?
Thanks, Lily. So yeah, I think all these programs are really exciting. The thing about private sector engagement is that there's some science, but there's a lot of art to it. And I think you can see that, all these programs show that, many of them started with strong assessments to be able to understand what the barriers were and to really listen to the private sector and build on those. USAID really wants to be a co-creator with the private sector and think about co-creation and co-financing. And I think these projects all exemplified that. And then I think, nobody knew that we were going to have a global pandemic in the middle of these programs. But I think, one of the advantages of the private sector is really their ability to be very flexible and adapt kind of on a dime. And so I think all of those are things that, these projects have learned along the way. And I think, the work of private sector engagement is an ongoing process. So I think I've learned a lot from all these presenters, and I think these are all, there's no one way to do private sector engagement. And I think this panel has shown that there's a breadth of different ways to do engagement.
Thank you, Susan. We just have 2 minutes, and maybe I should I'd like to share with you some of my thoughts about what I heard this morning. I want us to sort of think back on the title of this presentation. It says COVID-19 and beyond. And I began to think, what does and beyond mean? We're right in the middle of a pandemic. we can hardly think of what's going to happen beyond this pandemic. So, but from what I heard, there are actually things that are happening in all these programs that are really good. It just shows how resilient our partners are, the private sector is, and how, you know, much of that can actually move beyond the pandemic. Hopefully the pandemic will not last too long. And I just feel like we are leapfrogging into the world of technologies, and that's really working well. So I just see a lot of telemedicine happening in all the 3 countries. I see remote mentoring. I see training, as India calls it, touchless care. And so really the use of technology that defines our generation, I think, is what's going to make us even more resilient. And I think that's one of the best lessons that we are learning from this pandemic that will go well beyond the pandemic. The other thing I'm learning is that, you know, infection prevention and control was so sort of ho-hum in the past. Okay, wash your hands. Okay, get the soap there. But now it means life and death, and it has become the core element of our quality of care. So I hope that's here to stay. And the other thing about the title is that it says, is the private sector part of the solution? In my mind, there is no question that is part of the solution. And it's, you know, we should just sort of engage the private sector more, support it where we can, and really it has been so invisible, at least in the discussion these days about the pandemic, and it should no longer be invisible. So I really believe it is a part of the solution. The whole market approach is so very important. And I'm so glad that this private sector panel today shared with us some of their lessons on how they have actually engaged the private sector. So with that, I think I'll turn it over to Bethany.
Thank you so much, Lily, and thank you so much to our panelists. I'm going to now hand it over to my colleague, Sadia, to wrap us up. Thank you.
My pleasure. Thank you very much, Bethany. And thank you to all the presenters. And as you've heard, everyone, that today Susan shared USAID's private sector engagement strategy and principles that focus on a shift to pursue market-based approaches to accelerate progress on the journey to self-reliance. And we also heard our experiences from implementers in the field that were very insightful. So to me, I mean, I would like to echo Lily in that it's really clear that the private sector can and needs to be involved in delivering quality services across the board. The COVID-19 pandemic really provided us with an opportunity for the private sector to serve as a partner to the public sector. And our speakers mentioned several ways that we could continue to build on this momentum, like early engagement, effective stewardship, supportive regulatory mechanisms, harmonized approaches to resourcing, capacity building, and quality of care. So what happens beyond COVID-19? Again, while I don't have a crystal ball to give us the answer, what we heard today signals very new and innovative sustainable ways of planning, resourcing, and delivering services to the hard-to-reach populations and the urban workforce alike. And the private sector definitely has a very strong role to play here. And in that vein, on behalf of Palladium, I would like to thank USAID, particularly Lily Kaak and Susan Ray Ross, for their insights and guidance as we worked on this webinar. And thank you also to all the presenters, moderators, and discussants, and to you, the participants. I wish you a wonderful rest of the week. Stay safe, stay strong.
Thanks, everyone. We'll see you back here next time.
Thank you so much.
Thank you.
Thank you.
Thank you.